Brothers and sisters, citizens, part 2, continuing the reading of the book The Management of Working Capital in Hospitals. Had to interrupt because I had run out of battery on my laptop, which is not the best. See, again, this Coffee with Dragon, special emergency crisis war cup of coffee is dedicated to my brothers and sisters, soldiers on the front lines against the war, fighting the war against the coronavirus, the healthcare professionals, the nurses, the doctors, my brothers and sisters, fellow citizens, the front lines, our soldiers now, this war, we're fighting hard. This reading session is dedicated first and foremost to you. Again, I'm calling on joining citizens to join the Corona that is the Citizen Corona Committee. I'm calling for the creation of an integrated volunteer army, integrated with all public and private organizations to ensure these three things: food, housing, and transportation security, starting effective today, March 20 until June 21st, if not latest date April 1st to July 1st, to ensure these three: food, housing, and transportation is secured, free of any financial cost, by a public-private partnership, and calling for this creation of the volunteer citizen army integrated with all public-private organizations and institutions. To our brothers and sisters on the front line fighting the war against the coronavirus, this reading is for you. Yours truly, Adrian H. Dragon, is offering as an artist, athlete, and activist. To that trinity, adding the fourth dimension of being a spiritual teacher, adding the offers of free hugs, free citizen massages, free hand washing, free feet washing on Mount Royal once, and we will be victorious in this war against the coronavirus. Once this war is, we've conquered it triumphantly, emerged victorious together. Beloved, I love you. To you. Peace. Chapter 3: Financing Hospital Care in Canada. Objectives. After completing this chapter, you should be able to 1. Describe the insured inpatient, and outpatient services in Canada. 2. Describe the other sources of revenue earned by the Canadian hospital. 3. Describe costs that are recoverable by the Canadian hospital. 4. Describe the method of determining the federal contribution to the health programs of the provincial government. 5. Describe the methods employed to finance the provincial share of health costs. 6. Describe the methods used by provincial authorities to pay participating hospitals. Introduction. Again, to my brothers and sisters, soldiers on the front lines now, or citizens, fellow citizens, nurses, doctors, healthcare professionals, fighting the war against the coronavirus. Introduction. In Canada, the financial environment of the hospital is dominated by a governmentally supported system in which the institution receives a series of prospective payments that usually are made before the service is provided. Since 1956, a more or less fixed and homogeneous set of inpatient services and a more heterogeneous bundle of outpatient services have been financed jointly by the provincial and federal governments. When discussing the insured benefits and methods of making payments to the hospital, it is necessary to focus on the Hospital Insurance and Diagnostic Services Act and the Federal Provincial Fiscal Arrangements and Established Programs Financing Act of 1977. The basic inpatient benefit structure offered by all hospitals is specified in the Hospital Insurance and Diagnostic Services Act, which, prior to April 1st, 1977, also contained the formula used to determine the federal contribution to the various provincial programs. With the passage of the Federal Provincial Federal Fiscal Arrangements and Established Programs Financing Act on April 1st, 1977, however, the responsibility for administering the system of financing health and hospital services shifted from the federal government to provincial governments. Since these two acts have dominated the hospital financial environment, the following discussion considers their provisions in some detail. Benefit structure and sources of revenue. Among the primary objectives of the Hospital and Diagnostic Services Program is to ensure that the receipt of service is determined by medical need rather than by economic status or ability to pay. Pursuant to this major goal, the Hospital Insurance and Diagnostic Services Act specifies a set of inpatient benefits to which residents of each province are entitled without direct charges. The exceptions to this rule involve authorized and differential charges that are described below. Inpatient benefits. Table 3.1 lists and explains the inpatient services that are insured benefits in each province. Several comments concerning this benefit structure are appropriate. As noted above, the insured inpatient is entitled to the set of services listed in this table without additional direct charges. However, when a patient occupies a private or semi-private room, the individual is responsible for the portion of the rate that is in excess of that for standard ward care. The fee for occupancy of a preferred accommodation is referred to as a differential charge. Several provincial plans have co-insurance provisions that require patients or the third party to pay an authorized charge, usually a fixed charge per day. And now I'm making a call to the third parties, are especially the athletes of Canada who have been blessed, such as those playing for the NHL or the NBA, Toronto Raptors, Montreal Canadiens, Calgary Flames, Vancouver Canucks, Toronto Maple Leafs, who are millionaires, to give at least 10%. Inflected now, starting when you hear my voice. I don't know when this is going to be posted in the next 48 hours or so, at 72 hours max. Please do so. As a third party citizen financing the healthcare system. Outpatient benefits. With respect to outpatient services, the Act guarantees federal participation in financing the use of any or all of the services specified above when they are provided on an outpatient basis. However, each province is allowed to determine which of these services will be incorporated as an insured benefit when used by outpatients. Unlike the set of insured inpatient services, the extent to which outpatient care is insured varies among the provinces and territories. Table 3.2 summarizes the major outpatient services that are insured benefits in each of the provinces and territories. This table demonstrates that insured benefits are not uniform across provinces. For example, all outpatient services provided by the hospital, including physiotherapy and dietetic counseling services. Table 3.1 Insured inpatient benefits. I'm going to be reading from this. Table 3.1 Insured inpatient benefits. Accommodations and meals at the standard ward level. Accommodations and meals at the standard or public ward level is an insured service provided in all Canadian hospitals, except institutions approved for outpatient services only. Required nursing services. Necessary nursing care in an insured service provided by all hospitals. However, the care provided by a private duty nurse, as defined in the usual way, is not included as an insured service. Laboratory, radiological, and other diagnostic procedures. In addition to the set of diagnostic and monitoring services provided by the hospital, the Act specifies that any necessary interpretation of the result of such procedures also is an insured service. Drugs, biological, and related preparations. The drugs included as an insured service vary from province to province, and only drugs specified in provincial agreements and administered in the hospital are considered to be an insured benefit. Use of special rooms. Included in this benefit are the use of operating rooms, case rooms, and anesthetic facilities, including equipment and supplies. Routine surgical supplies. This benefit includes surgical dressings and other materials required during or following an operation. The benefit does not include prosthetic devices that may be required unless the appliances are used while the individual is a patient in the hospital. Radiotherapy. In hospitals with radiotherapy facilities, the use of these facilities is included as an insured benefit. This includes, for example, the use of equipment and facilities for superficial and deep X-ray therapy as well as cobalt, radium, and other radioactive treatments. Physiotherapy. Even though numerous hospitals have a physiotherapy department or physiotherapy facilities, these facilities are not available in smaller institutions. Where these facilities exist, physiotherapy services are included as an insured benefit. Other services of hospital employees. In addition to the previous factors, the services provided by individuals who have contractual arrangements with the hospital are included as insured benefits. For example, the services of physiotherapists, radiotherapy technicians, occupational therapists, and social workers are insured benefits if such services are incorporated in a provincial plan. Further, the services of interns, residents, or physicians engaged in hospital administration or in the direction of medical departments are included. Other services specified by the province. In addition to the services specified above, the province may decide to include additional ones in the set of insured benefits. As an example of special services, the province may decide to develop specialized programs for the diagnosis and treatment of cancer. For such services to be considered an insured benefit, they must be available to all residents of the province after a proper medical referral. And continuing from, for example, all outpatient services provided by the hospital, including physiotherapy and dietetic counseling services, as well as all outpatient services offered by provincial cancer clinics and diagnostic services at provincial laboratories, are benefits that are insured by the Alberta Health Services Commission. A somewhat less comprehensive approach has been taken by the provincial plans of Saskatchewan, New Brunswick, Manitoba, and Newfoundland. Even less comprehensive is the outpatient coverage offered in the Yukon Territory and the Northwest Territory. Table 3.2 Summary of insured outpatient services in Canada by province. Province or territory. British Columbia. Emergency services, minor surgical procedures, daycare surgical services, outpatient cancer therapy, psychiatric day and night care, daycare rehabilitation, narcotic addiction services, physiotherapy, diabetic daycare, and dietetic counseling. Alberta. All outpatient procedures provided by the hospital. All diagnostic, physiotherapy, and dietetic counseling services. All outpatient services provided by provincial cancer clinics and laboratories. Saskatchewan. All outpatient services provided by the hospital. Manitoba. All outpatient services except drugs and dressings in certain cases. Ontario. Most outpatient services including physiotherapy, occupational therapy, radiotherapy, and inhalation therapy, as well as the other hospital services when medically necessary. Quebec, where yours truly resides. 24-hour emergency service. Minor surgery, including X-ray and laboratory examinations, physiotherapy, radiotherapy, occupational speech and audiology therapy, and medical orthoptics. ORTHOPTICS. Medical orthoptics. New Brunswick. All approved available services. Nova Scotia. Broad range of essential services including medically necessary diagnostic and laboratory examinations, radiotherapy for non-malignant conditions, physiotherapy. Continuing province or territory. For Nova Scotia, there's still more. Hemodialysis, emergency diagnostic and treatment services within 48 hours of an accident, minor medical and surgical procedures, and dietary counseling. Interesting. Prince Edward Island. Basic laboratory and radiological diagnostic procedures, radioactive isotopes, drugs and related preparations for emergency diagnosis and treatment. All other services specified as inpatient services. Newfoundland, laboratory, radiological and other diagnostic procedures, radiotherapy and physiotherapy, occupational therapy, outpatient visits, emergency room visits, operating room facilities, drugs, medical and surgical supplies when provided in the hospital. Yukon Territory, diagnostic procedures, treatment or injury, illness or disability excluding normal physician services, daycare surgical services. Northwest Territory, emergency and follow-up treatment of injury, radiological diagnostic procedures, laboratory examinations, minor surgical procedures, physiotherapy and radiotherapy, certain daycare surgical procedures. Other sources of revenue. Although most of the institution's revenue is earned by providing insured services to the population covered under the provincial plan, the Canadian hospital also earns income from services that are insured by other third-party payers. Again, calling on the most blessed financially of our society, athletes, artists, Celine Dion, or others. Please be that third party. Donate 10%. R. Continue. Third party payers. The hospital earns revenue by providing service to patients who are covered by other governmental agencies such as the municipal, provincial, or federal governments, as well as those whose care is financed through the Workmen's Compensation Board. To a lesser extent, the hospital may earn revenues by providing services to insured patients who are not residents of the province in which the institution is located. In such cases, the income from this source consists of direct charges to the patient or to the provincial plan concerned. The final source of operating revenue involves the portion of hospital charges that represents the financial liability of the patient. The situations in which the patient is responsible for a portion or all of the hospital charges may be summarized as follows. 1. Inpatient use, authorized charges. B. Differential charges. C. Uninsured patient. 2. Outpatient use, authorized charges, uninsured services, uninsured patient. With regard to inpatient services, it will be recalled that a differential charge is imposed directly on patients or third-party payers for the use of preferred accommodations, while the authorized charge represents a deterred fee that is assessed in several provinces. As was seen earlier, the composition of insured outpatient benefits varies from provincial plan to provincial plan. When these services are not included as an insured benefit under a third-party contract, the financial liability resulting from their use rests with the patient. The responsibility for a portion of all of the costs of care for an insured patient might be assumed by the individual. When compared with the provincial plan and other governmental units, the hospital can place far less reliance on actually receiving payment from the patient. This is so for several reasons. First, as in the United States, the unwillingness of Canadian hospitals to pursue vigorous collection procedures or to assess carrying or interest charges on unpaid balances in patients' accounts has placed the institutions at a comparative disadvantage when competing with other creditors for payment. The second factor involves the possibility that the illness for which the patient received service reduces the individual's ability to perform normal economic functions and limits the capability to earn income. And this is exactly the situation with COVID, the coronavirus, where we are in Canada, locally, nationally, North America, the United States as well, and worldwide. Worldwide. Second factor involves the possibility that the illness for which the patient receives service reduces the individual's ability to perform normal economic functions and limits the capability to earn income, which is the case now. Second factor involves the possibility that the illness for which the patient received service reduces the individual's ability to perform normal economic functions, and limits the capability to earn income. The first factor obviously influences the patient's willingness to pay. The second influences the ability to pay. Both tend to reduce the probability that patients will honor their financial liability to the hospital. Finally, the Canadian hospital may earn non-operating revenue by selling goods and services to individuals or institutions other than the patient. For example, the hospital may sell dietary services, laundry services, or heat or steam to other healthcare facilities. In addition, income may be derived through the rental of rooms or other accommodations, as well as of land and buildings owned by the hospital to persons or institutions other than patients. In these instances, the income earned is referred to as a recovery, and the entity responsible for payment frequently is another healthcare institution, such as a local nursing home or another hospital. In these instances, the income earned is referred to as a recovery, and the entity responsible for payment frequently is another healthcare institution, such as a local nursing home or another hospital. In these instances, the income earned is referred to as a recovery, and the entity responsible for payment frequently is another healthcare institution, such as a local nursing home or another hospital. Allowable costs. Most provincial plans and other third-party payers recognize the direct and indirect expenditures incurred in providing insured services as allowable costs. These cost elements are as follows. 1. Cost of employment. This category includes wages, salaries, and employee benefits, with the exception of a few minor items. All employee costs are regarded as shareable by all provincial plans. Cost of purchased services. In this category are the costs of services that are primarily substitutes for employment costs. Consumable supplies. This category covers the costs of supplies used in the production of service as well as in the maintenance and operation of the hospital. 4. Occupancy costs. This category includes costs related to heat, light, power, etc. In addition, most provincial plans recognize depreciation charges on major equipment, non-movable equipment, and outright purchases of equipment. When calculating the expenses that constitute the basis for provincial plan payments, the hospital must deduct certain items for recorded costs. These items are regarded as sources of revenue that compensate the hospital for costs incurred in providing an insured service. Since the hospital will recover these expenses from non-plan sources, most provincial plans require that the institution deduct the items listed in Table 3.3 from recorded costs when determining allowable costs. It is important to note, however, that the offset revenue recognized by most provincial plans do not usually include such items as gifts, bequests, endowments, chapel receipts, contributed services, or investment income. As a result, these items are not treated as offset revenue and need not be deducted from total recorded expenditures when determining allowable costs. In addition to the items of offset revenues summarized in Table 3.3, most provincial plans exclude certain items from allowable costs. Table 3.4 lists the major expenditures that must be excluded by the provider in most provinces when calculating allowable costs. Most of these exclusions are self-explanatory, but several deserve further comment. As noted in the table, any account amounts expended on land improvements, buildings, built-in equipment, and building service equipment, as well as any provision for depreciation on these items are not regarded as allowable costs in most provinces. Most provincial authorities would defend this exclusion by noting that the acquisition of these items was financed primarily through governmental grants. Since governmental agencies provide most of the funding for the construction of the hospital's physical plant, there is no reason to recognize depreciation charges, debt principal, or interest charges related to the acquisition and use of these capital assets. As indicated, any provision for depreciation on the value of the hospital's physical plant is not recognized as an allowable cost by most provincial authorities. It should be noted, however, that the term physical plant usually is defined to exclude furniture and movable and non-movable equipment designed specifically for use in a hospital. As a consequence, most provinces recognize depreciation charges on these items as allowable costs. In many provinces, the hospital cannot recover the cost of research from provincial authorities. Thus, gross wages and salaries, the cost of medical, surgical, and pharmaceutical supplies, and any outlays for equipment purchased for the express purpose of conducting research are not recognized as allowable costs in most provinces. This exclusion is justified on the ground that most research in Canada is financed through federal and provincial grants. As a consequence, most provincial authorities would argue that funding provided through such grants is sufficient to finance most hospital-based research. Table 3.3 Major items of offset revenue. Differential charges. Explanation. A portion, usually 50% of the revenue earned by providing federal accommodations, is treated as offset revenue. Receivables generated by providing service to patients, such as members of the Royal Canadian Mounted Police or the armed forces who are entitled to service under any act of Parliament or any other legislation or jurisdiction, usually are deducted from total costs. In addition, amounts owed by other provincial plans or other entities are regarded as offset revenues. Grants. Contributions or national health grants intended to finance current operating activity or teaching and research programs usually are deducted from total costs when determining allowable costs. That is in the grants. Recoveries. Cash received or income earned by engaging in recovery transactions is treated as offset revenue. Cash discounts. Total recorded costs are reduced by the amount of cash discounts on purchases made by the hospital. This deduction pertains only to institutions using the gross invoice method of recording accounts payable. This deduction is justified on the ground that cash discounts do not involve the cash disbursement by the hospital and necessary services. The earnings from insured services, the use of which is considered to be unnecessary by provincial authorities, must be deducted from total costs when determining allowable costs. Financing mechanism. As mentioned, the costs of hospital care in Canada are financed jointly by federal and provincial governments. In describing how the cost of hospital care is financed, the first consideration is the method of determining the federal contribution to hospital operations and then the various methods employed by provincial governments to pay for their share of hospital costs. Table 3.4 Major cost exclusions. Item. Capital cost. Explanation. This exclusion refers to amounts expended on land, land improvements, buildings, building equipment, and building service equipment. Capital debts. Amounts expended on payment of capital debts and any interest on such debts usually are excluded from allowable costs. Depreciation. The exclusion covers any provision for depreciation on the value of land, land improvements, and the physical plant of the hospital. Prior debts. This exclusion involves any amounts expended for the payment of debts prior to the enactment of legislation creating governmental responsibility for financing hospital costs. Research costs. This exclusion pertains to any direct or indirect costs incurred in whole or in part in research purposes. Cost of commercial operations. This exclusion refers to the direct and indirect costs incurred in the operation of commercial enterprise, such as the hospital gift shop, barber shop, etc. The federal contribution. The basic trust, that's trust with an H, THRUST, of the Federal Provincial Fiscal Arrangements and Established Programs Financing Act of 1977 was to establish the basis for determining the federal contribution to the hospital insurance programs of the provinces and territories. It is important to note that, apart from altering the formula for determining the amount of the federal contribution, the Act did not change any of the other provisions of the Hospital Insurance and Diagnostic Services Act. As a result, the contribution of the federal government under the 1977 Act remains conditional on the preservation of the structure of insured benefits guaranteed by the Hospital Insurance and Diagnostic Services Act. Since April 1st, 1977, the new arrangement has constituted the basis for determining the amount of the federal contribution to the provinces and territories to help them provide 1. Hospital services as defined by the Hospital Insurance and Diagnostic Services Act. 2. Physician services. 3. Extended health care. 4. Post-secondary education. Extended health care is recognized specifically by the legislation. The major purpose of this provision is to give the provinces flexibility in determining the manner and form in which these services are provided. Depending on local requirements, some provinces may emphasize home care as a low-cost alternative, while others may emphasize ambulatory or residential care. The annual federal contribution to these areas of program activity consists of 1. A reduction in federal income taxes that enables provinces to increase provincial taxation without a net increase in the total level of taxation. 2. A set of cash contributions consisting of 1. A basic cash contribution. B. A leveling payment. Of these components, the basic cash distribution is perhaps the most important. That is because this element comprises approximately half of the federal funding of the established programs. Given the importance of the basic cash contribution, this component is considered first. Basic cash contribution. The basic cash contribution is based on the total amount paid by the federal government in support of hospital insurance, medical care, and post-secondary education programs during the fiscal year 1975-1976. The calculation of the basic cash contribution requires the following steps. 1. The basic per capita rate, PCR, is obtained by dividing the total federal contribution to these programs during 1975-1976 by the total population in 1975-1976. Thus, PCR equals total federal contribution in 1975-76 divided by the population. So today, population stands at about 37 million, more than 37 million today, March 20th, 2020. Where PCR is the per capita rate. 2. The per capita base is then derived by multiplying the per capita rate by 1/2, to which 7.66 is added. Thus, PCB equals 1/2 of, per open parenthesis, PCR plus 7.63, where PCB is per capita base. 3. The basic federal cash contribution, BCC, to a given province for any fiscal year is derived by multiplying the per capita base by A. The population of the province for the fiscal year in question. I guess for Quebec we're about 7.7 million, if not a bit more than 8.5 today. B. An escalator adjustment equal to the 3-year compound rate of growth in the gross national product, the GNP, as expressed in current dollars. Thus, the basic cash contribution to a given province, J, for the fiscal year T is given by BCC or JT equals PCB times PJT times the special A there. It's a mathematical formula basically. So that's the formula, where PJT represents the population of province J in time T, and A represents the 3-year compound rate of growth in GNP. leveling payments, as seen, the national per capita rate, which is based on the total federal contributions during the fiscal year 1975-1976. So these fundamentals still apply pretty much the same way today in 2020, March 2020, as this was written in March 1981. Was employed in calculating the basic cash contribution to a given province. Prior to the Act of 1977, provinces in which the per capita cost of hospital care exceeded the national average received a relatively low percentage of their costs from the federal government. Those where these costs were less than the national average received a relatively high percentage. As a consequence, the federal per capita contribution varied from province to province during fiscal 1975-1976. By implementing the national per capita rate immediately, the Act of 1977 would have exerted an adverse effect on some provinces and a beneficial effect on others. Provinces that received a relatively high per capita federal contribution would have suffered a loss had the national average been used immediately to compute the basic cash contribution. Conversely, provinces that received a relatively low per capita payment from the federal government would have experienced a windfall gain. Therefore, a leveling payment was added or subtracted from the federal cash contribution to each province in the following fashion. 1. Provinces that received a per capita federal contribution in excess of the national average in 1975-76 were to remain somewhat above the national average during the first 4 years of operation under the new legislation. By the fifth year, after narrowing the gap between the per capita rate in 1975-76 and the national average by 20% per year, these provinces were to be receiving the national average payment. Provinces that received a per capita contribution from the federal government in 1975-76 that was less than the national average remained somewhat below the national average during the first 3 years under the new legislation. By the third year, after narrowing the difference between the per capita contribution from the federal government and the per capita contribution in 75-76 by 1/3 each year, these provinces also were receiving the national average payment. In short, then, provinces gradually moved through a series of leveling payments from the per capita contribution received in the base year to the national average payment in 3 to 5 years. Reduction in federal income taxes. The reduction in federal income taxes consists of 1. A transfer of 13.5 personal income tax points. There's a special star, and that is, from the perspective of the federal government, the value of a tax point is equal to 1% of the basic federal taxes generated by a specific tax base such as personal or corporate income. From the perspective of the provincial government, the value of the transfer tax point is equal to the number of transfer points multiplied by the value of a tax point in the province. A transfer of 13.5 personal income tax points from the federal government to the provincial government. 2. A transfer of 1 corporate income tax point from the federal government to the provincial government. The reduction in federal income taxes enables the province to increase the level of provincial taxation in these areas without a net increase in its total level of corporate and personal income taxes. Thus, the transfer of tax points from the federal government to the provincial governments simply alters the composition of taxation without a net increase in the total level of corporate or personal income taxes. 3.4.2. The provincial contribution, presented in Table 3.5, is a summary of the various methods employed by provincial governments to finance the portion of the costs of hospital care that are not the responsibility of the federal government. In accordance with the legislation enacted in 1977, all provinces rely on general revenues to finance the costs of health and hospital care. In addition, an inspection of the table will reveal that several provinces also employ premium payments as well as direct patient charges as a major source of required funds. Methods of payment. 3.5. The amount of the contribution to hospital operations by the provincial plan is determined by the hospital's budget, which must be approved by provincial authorities. Once approved, the hospital receives 1/12 or 1 1/24 of the annual budget in monthly or semi-monthly installments respectively. The purpose of these payments is to finance the operations of the hospital on a current basis until the next pay period. Presented in Table 3.6 is a representative sample of the methods employed by the provinces in paying participating hospitals in selected provinces. Table 3.5 first. Provincial healthcare financing methods before 1977 Act. So you have an idea there. Which were so the provinces, so general method of financing, general revenue in whole, in part, premium, or patient care. Since the preparation of the budget and the resulting periodic disbursements from the provincial plan to the hospital are based on expectations and predictions, each plan allows for periodic or end-of-year adjustments. These adjustments reflect the fact that the actual performance of the hospital is seldom, if ever, in balance with the expected performance as expressed in the budget. The adjustment process, then, is the mechanism by which the hospital might be compensated for justifiable deficits. On the other hand, if actual costs are less than budgeted costs, the hospital may be forced to reimburse all or a portion of the surplus to the provincial plan. As noted in Table 3.6, which we haven't looked at yet. It's there on the next page. The adjustment process usually occurs at year's end after an external audit of the hospital's books has been completed. In seeking additional funds, the hospital usually must prove that the deficits were due to changes in volume, standards of care, or unusual circumstance that could not be foreseen at the time the budget was prepared, such as the coronavirus ongoing crises, emergency, and war. On the other hand, if actual costs are less than budgeted ones, in certain provinces such as Manitoba, in seeking additional funds, the hospital usually must prove that the deficits were due to changes in volume, standards of care, or an unusual circumstance such as the coronavirus that could not be foreseen at the time the budget was prepared. The COVID-19 crisis, for example. In certain provinces such as Manitoba, a firm budget procedure is in effect and the hospital is responsible for any deficits. 3.6 Summary and implications for working capital management. The last two chapters have examined the financial environment in which working capital is managed in Canada and the United States. That hospitals in the two countries depend on third-party payers. Again, I'm calling on our athletes, artists who are blessed with millions, businessmen, bankers who are blessed with millions. Give at least 10%. I'll hug you for it, kiss you for it, tickle you for it. All right. Do it now, March 20. Latest April 1st. Table 3.6. First, depend on third-party payers and to a lesser extent self-pay patients as a major source of revenue and cash should be clear. Also shown was the fact that the lion's share of the United States hospitals reimbursement is received on a retrospective basis. Most of the average Canadian hospitals on a prospective basis. Table 3.6 Methods of paying hospitals in selected provinces. Province Manitoba. Method of payment. 24 payments per year based on approved annual budget. Adjustment process. Hospital usually are responsible for any unfavorable differences between actual and budgeted cost. On the other hand, they are permitted to retain a small percentage of any surplus. Prince Edward Island. 12 monthly payments based on the approved budget less 50% of all differential revenues earned by the hospital. Standard ward rates reimbursed by bulk payments. Adjustment process. Adjustments during the year are negotiated on the basis of material differences between actual and budgeted rates of activity. Year's end adjustment is negotiated after audit. Audit. Newfoundland. 24 payments per year based on approved annual budget. Hospital adjustment process. Hospital may request budget review after mid-year, June 1st. Final review and adjustments occur at year's end. British Columbia. 24 payments per year based on approved annual budget. Adjustment process. Adjustments made when occupancy rates are markedly different from budgeted standards. Adjustments equals variations in days times value of one day's supplies. Alberta. 12 monthly payments based on approved annual budget. Adjustment process. Adjustment permitted if the hospital can prove a deficit is due to unusual circumstances such as the COVID-19 crisis, for example. Can be others, of course. Saskatchewan, 24 payments per year based on an approved annual budget. Adjustment process. Rates are changed if volume or standards of care change. Adjustment made at year's end, and the hospital may retain surplus if it was a result of efficient operation. Despite these differences, the basic techniques of working capital management may be used appropriately in both systems of reimbursement. To illustrate this point, consider the impact of these two systems on the problem of estimating the cash inflows for some specified period. Under retrospective reimbursement, the hospital's cash inflows depend on the rate at which payments are made on receivables. When estimating these cash inflows, it is convenient to divide the amounts owed to the hospital in essentially two groups. The first group consists of receivables for which a third-party payer, example Blue Cross, Medicare, the commercial insurance company, etc., assumes financial responsibility. For this group, the amount of the payment usually is known with certainty, but the timing of subsequent cash receipts is far more problematical. The second group consists of accounts receivable for which the patient assumes financial responsibility. In this case, neither the amount nor the timing of subsequent cash receipts can be known with certainty. A similar situation arises under prospective reimbursement. As seen above, the cash receipts of such a hospital consist of random and non-random components. With regard to the non-random component, the timing and the amount of the periodic prepayment is usually known with relative certainty. On the other hand, the random component depends on the rate at which payments that is, are made on receivables. As before, the accounts receivable of such a hospital may be divided into two groups. The first group consists of receivables for which a third-party payer, example, other provincial plans, commercial insurance companies, workmen's compensation board, etc., assumes financial responsibility, while the second consists of amounts owed to the hospital by self-responsible patients. Factors that give rise to this component are the imposition of direct patient charges, as well as the use of uninsured service. As before, management usually is certain of receiving payment in full from the third-party payer, but is less certain of the timing of these receipts. On the other hand, management is certain of neither the amount nor the timing of cash inflows from patient payments. These observations suggest that hospitals in Canada and the United States are faced with similar problems when estimating the cash inflows from payments on receivables. In the case of the third-party payer, only the timing of cash receipts is problematical, and it will be seen that an application of the principles of mathematical expectation permits an estimation of the magnitude of cash receipts during a given period. When estimating the cash inflows from payments on the receivables for which the patient is responsible, it is necessary to address not only the problem of estimating the timing of these receipts, but also the value of the accounts that will be paid in full and the value of those that must be written off as uncollectible. In this regard, an absorbing Markov chain which is a method of estimating the value of outstanding receivables that will be paid in full or written off as uncollectible, would be found to be a useful management tool. These probability models may be used appropriately in both systems of reimbursement. Concerning the other components of working capital, administrators in the United States and Canada are faced with similar problems when managing inventories, and the institution's investment in marketable securities, as well as when reaching decisions regarding the best method of financing working capital needs. As a consequence, the tools and techniques of working capital management are appropriate to both systems of reimbursement. At this point, it is important to note that the last two chapters provided a basis for subsequent analysis of the tools and techniques of working capital management. In addition, it will be found that many of the techniques discussed in this text may be expressed by using the notation and operations of matrix algebra. Thus, before discussing working capital management and the process of internal control, it is necessary first to review the basic principles of this area of mathematics. Brothers and sisters, that was the management of working capital in hospitals, read by yours truly, Adrian H. Dragan, independent citizen, artist, activist, and athlete, dedicated to our brothers and sisters on the front lines of this war against the coronavirus, the nurses, the doctors, the healthcare professionals working hard. Yours truly, this is for you primarily, and I'm calling on all to join the Citizen Corona Committee, where I call for the creation in the coming days, weeks, and months ahead of a integrated volunteer army to primarily secure these three demands, principles: food, housing, and transport security, regardless of financial cost, that is free for all citizens, locally, nationally, and internationally. And this creation of this army, a volunteer citizen army to be integrated with all public and private organizations and institutions at all levels. I've written theory about it. More will come in the coming days, weeks, months ahead. But this is the main general proposition calling for this. Part of my Citizen Corona Committee, which you can find as a Facebook group. Again, this reading session has been dedicated and is dedicated to my brothers and sisters on the front lines of the war, soldiers, now our healthcare professionals, doctors and nurses, who's working in healthcare and hospitals. I'm with you at the end, and we will win this war. I'm offering you free hugs, free massages, citizen massages, hand washing and feet washing even, for your pleasure, relaxation, and recreation on Mount Royal after we win this battle together. Myself have not any of the three symptoms: coughing or fever or respiratory problems. But if you do have any of those symptoms, please, depending on their severity, consult the number provided by your government and healthcare professionals or on the news. And if they're severe, you go to a clinic. And if they're very severe, say to assess yourself, monitor yourself for those three symptoms. If you're very ill, then go to the hospital if you have to. Emerging crisis, emerging situation. This coronavirus has, of course, spawned subsequent stock market crash, as we have seen in the past 3 weeks. Worldwide stock market crash, triggering financial crises. Worst case scenario, financial collapse. But as we've seen, the management of working capital, this is basically finance and healthcare, financing hospitals. And we have seen many principles, ideas, and fundamentals that are very much at work today in this time of crisis fighting the COVID-19. Beloved, and I love you. Wash your hands with soap often. Self-isolate if you have any of the three symptoms. And if you're very ill, go to the hospital. And of course, if depending on the situation, social distancing. My brothers and sisters, millennials, this is serious. The cases are exponentially increasing. People are dying, and it's tough times. Myself, what I will do is create my art here in this room off the some temple, which will begin a 22-day cleaning journey, and we're gonna do it. I'm gonna work out. Part of my 300 workout challenge will continue in the coming days, weeks, and months ahead. I'm putting it online from right here, this office room and temple, and to that trinity of fourth dimension of I served as a gymnasium in the past 2 years where I've lost more than 65 pounds and will continue to do so as I've done this week. Posted one already. Again, this is for my brothers and sisters, soldiers now, nurses, healthcare professionals, and doctors. This reading session has been for you.